All right, everyone, it's 1:45. We're going to reconvene after our lunch break, and we have the team from Nathaniel Witherell here today. Leo's just getting another mic, so whoever's speaking, I just would ask that you press the button so the light turns green and then turn on. We have here John Mastronardi, the Executive Director of Nathaniel Witherell. Welcome. We have Peter Kelly, Chair of the Board. We have Brad Radulovaki, Chair of the Finance Committee. We have Kelly Nardone, Chief Financial Officer. We have Kate Tabner, Board Member, and I believe Chair of the Legal, Vice Chair, okay? Excuse me, Vice Chair. I should have let you guys introduce yourselves. I took a leap. But welcome. And Peter, I believe you have some introductory comments?
Yes, I do. Thank you, Laura. And I thought if we had 5 people here, we could overwhelm 4, but I'm not sure that's going to work that well. But anyway, no, thank you for having us here, and I do want to make a few opening comments. You have the financials for the first half of this fiscal year, and I'm sure you, like we, are very concerned about where they are. I mean, it's not the outcome that we expected, and it's something that we want to address as quickly as possible. To that end, what we'll present as quickly as possible today, because I'm sure there'll be a lot of questions, is what our 16-month turnaround plan is. It was what we're really focusing on. So we're focusing on the last 4 months starting March 1st of this year, and then through the 27 fiscal year, and the impact we believe we can have on turning those results around. I do want to mention, though, a couple of things before we start, because of a non-financial but important nature, and that is, what we've done in the last year. I think the most important thing we've done is we now have a management team in place that we did not have before. We were successful. Actually, he starts today in recruiting our new Director of Nursing Services, which is a very critical position. And our new appointee is actually undergoing the orientation with the town today, and we hope to have him in his office tomorrow. And clearly, nursing leadership is a major part of what we do because we are a long-term care nursing facility. We do have a medical director who has been on board now for over a year, and he has put together a program at Witherell where we are providing 7-day-a-week presence of medical care on the facility, and the medical care is available 24/7, which is a major plus. We obviously, and I won't make the mistake again, because we have a full-time director of finance right now who is doing this wonderful job, almost as good as her predecessor, Joan. And I'll never forget what I said the last time, Joan, so I won't repeat it. But seriously, that has really been a plus, because Kelly continues to have a relationship with Joan, and I think it's really been Joan's ability to continue to mentor Kelly has really been incredibly important. So we also have recruited a new Director of Operations, and that is critical because one of the things that I know we talked about in the meeting, when's it, Monday? Yesterday. No, yesterday was Monday. When John came before the committee to get the approval for interim funding is going to the BET, full BET tonight, it really is important that we now have a Director of Operations on that we have great confidence in, that we'll be able to really address issues, and we will not have a repeat of what we're dealing with now in terms of requesting a significant appropriation to that end. And the last thing I'll say is I talk about the board, and exclusive of myself. I think that we have a board now. In fact, I know we have a board now that is extremely committed to the success of Witherell. And we have a board structure now, and it was really begun by my predecessor, Brad Markowitz, in terms of getting a financial committee together. So we have a very well-functioning financial committee, we have a quality committee, we have a strategic committee, and we have a legal committee. And these are all chaired by members of the board, and clearly with Brad here, and I think it's probably because he's bigger than I am that I keep complimenting him, and I don't get in trouble with him, has really done an amazing job in terms of working with Kelly and being able to get us numbers and to get you numbers that are real, that are accurate, and are what we're basing off of. And even if the numbers are not good, we're going to give you those numbers, which we'll talk about more today. So these are a few of the things that we've done. We are focused on, and have in the last year focused on expense control. And I think that if you look at it over the last year, year and a half, you'll see that we have that under control in a much better sense. Certainly with the new director of nursing service, since the majority of our overtime is in the nursing arena, we anticipate that we'll have even better control over that. And lastly, we are examining what clinical programs that we should be providing and need to provide at Witherell to make us the most attractive provider of choice to acute care facilities and the patients who are discharged from those facilities, and being able to make sure that we're providing the appropriate complexity of care at the Witherell, and avoid admitting patients to the hospital, which has always been a problem, because the last thing you want to do is being ping-pong patients back and forth. So, but that all said, the most important thing today is to talk about what our finances are. And I want to turn that over to Kelly and Brad and begin that discussion. John will then make some more specific comments about what the 16-month turnaround plan looks like, and I just want to leave time for as many questions as you wish to ask, and we will answer. So, Brad?
Great, thank you, Peter. So,
Brad, you really just need to speak right to the mic.
oh,
Yeah, that's
here we
fine.
go. Is that good?
And just so we can follow along, we did get a handout,
Yes.
But are we following along with the
Yes, we're gonna
handout? Are we
follow-
going to
We're
the?
going to look at
Okay,
this one first, okay?
okay, all right. Because then
So-
you also sent in advance, Kelly sent it yesterday, the fiscal '26
Yes, yeah,
budget to
absolutely.
actual,
We're gonna
and,
get,
and, okay,
we're gonna
excellent.
get to that. So I would definitely say that during my tenure, my focus really has been to figure out management reports that are actually going to help us understand what's going on. And that's taken a long time, longer than I expected. And we're still working on it, and we'll have additional reports that will help the management team. But the first one I just think is important to look at is this, it's about 18 months, 19 months, long-term and short-term patient census trends. And, what you're going to see here is you're going to see that the census at the top line has declined by about 20 patients a day. It was in the high 70s at the beginning of fiscal year 25. It was July of 24, and it's declined into 157. We've got the last 3 months, it's been 157. So 20-bed decline in 18 months. That's quite a bit. So what's happening with that decline? If you look, it's really all coming from long-term beds. Long-term beds were at 140 in July of 24, and they're down to 121 today. The bottom line, the blue line, is short-term. That's short-term rehab. And I think the BT needs to understand, I think you probably do, that there's two separate businesses. There's a short-term rehab business that's outsourced, that is a high-margin business, that is primarily Medicare, managed Medicare, and maybe some private insurance. And then there's the long-term part of the business, which is all Medicaid, which is reimbursing at about half the rate of Medicare, all right? So the short-term business sort of fluctuates, but the average remains the same. And the contribution of short-term to the census is negligible. The people in short-term churn out too quickly. They're not there long enough to count for the census. They'll come in and they'll be out within a month, and that is not additive to census, all right? That's the conclusion is that short-term has high churn, length of stay is low, there's a lack of treat in place, that a lot of people turn into the hospitals, and even the training of the nursing staff isn't adequate to treat in place. And that's why, one of the reasons why churn is so high and short-term is not additive to census. And we're back to the middle line, which tells us that it's all about the long-term decline. All right? Can we go to the next one? I'm just sorry, before we go, just please notice at the end, here, at the end of the chart in the last 3 months, you can see that it actually fell off sort of a shelf. It's fallen from the, let's say, 170s into the 150s in terms of census, and long-term beds have fallen from, I don't know, 130 down to 120. So there's been a recent collapse, I would say. And we can move on to the next chart, which is this one. It's got a lot of, it says census calculator on the side here.
So Brad, I don't know your preference. Do you want questions as we go, or do you prefer to?
I think if I finish, I won't go too long. And
Okay, that's fine.
We can add questions. So if you go to this one, there's got a lot of numbers in this one, but I'll just point you to the important ones. Okay? Look all the way to the end, to the last 3 months, November, December, January. That's where you will see this collapse that I was talking about. So we went from a census of 172 in October of 25, and now we're down to 157, 156 in December. We're at the top of this chart. 157 in January, and February looks like it's going to be again around 157. So we're at another lower level of census. Why has it happened? Just a little lower down, you'll see that there's orange on two numbers, 97 and 81. That tells us that there's been a super decline in retention in short term. I was telling you that that's a problem. People churn out too quickly. They're churning out even faster now. So we've had a net loss of 1 patient in November, 6 patients in December. And if you just go further down, you've had a huge decline in long-term because we have not accepted many people and we've had a lot of deaths. So put all of that together and you're going to find that our census has declined by 7 patients per day in November and another 9 in December. That is the recent collapse. And finally, on the last part of this chart, you'll see in the green, there's a 0.9. That is the long-term contribution of rehab, the short-term rehab to census. It's just 1 patient per month over this entire period. Very low because of the high churn. If you look down a little lower, you'll see that long-term is a decline of about 3 a month because we don't accept enough and people do pass away. And then at the bottom, you'll see that the net decline per month on average has been about 2 patients a day over the last 18 months, just putting it all together. All right? We'll go on to the next slide. The next one is the denied patient numbers. Okay. So since we're trying to figure out, one, how to improve retention in short term, we're also trying to figure out how do we admit more in long term. And one of the glaring areas in the long-term admissions game has been denial of memory care patients. Our executive director tells us that in fiscal year 25, we denied approximately 50 patients for memory care. That is because we don't have the capacity to admit them. At least the institution has not been flexible enough to admit more memory care. This year, these numbers here in this chart are just for this year. And already in the last 7 months, we have denied 25 dementia. We've denied. And you can see that a lot of folks are right here from town. Denied 25, and mostly male dementia patients. So first of all, this is a good problem to have when you're falling in census. You actually have a group that demands your service and you're not offering it to them, right? So we know that there's a market for our services and we have to figure out how to tap it. The next chart is this one here. So this is just a very simple chart saying, look, we have 25 people that we turned away. Some of them, we won't be able to accept every one of these patients. They may not, be the right fit for us. But let's say we only accept a third, 8 of these 25 so far in the first half of this year. It's not even the full year. Based on the reimbursement rate, we would generate, if we held on to them for an entire year, 8 patients, $1.1 million in revenue. And that's incremental. That's incremental. We have the capacity, the staffing capacity, to take 8 people right now. I mean, we've lost 15 in the last 2 months. Of course, we can add people without incrementally increasing costs at this point, okay? So that's a clear opportunity for us. All right. And the last exhibit is this one. It's the financial projections. Okay. So, again, a lot of numbers, but let's just focus on the highlights here. What I wanted to show you is the current run rate. It's in orange. It's in orange in the middle of the page for the last 3 months, and I'm going through February because we pretty much know what February census is. It's in the 157s, all right? Our run rate right now is 157 in terms of census. That is an abysmally low census for an institution that's got 202 beds available, okay? If you go further down, you'll see what that means in terms of loss. Losses on operating profit. If we maintain this level, we're going to be losing $407,000 a month. Okay? So our big emphasis here in the short term to turn around this performance is to tap into the memory care patient base that I just showed you. We have demand that we haven't even touched. We want to start gradually improving acceptance of those patients. And in the green highlighted areas, we show 2 patients per month increase in memory care, which will increase our run rate on census to about 163 and start the journey higher, okay? And if you go further down, you'll see that that will improve our run rate of loss from 407 to 352. And that's a start. We obviously we want to do much better, but this is we have to fix this collapse in census. And this is a way that we know. It's not if, what we know we can do this. There are many other fixes that are still to be done, but we can't directly point to something and say, here is exactly how it's going to happen. This one happens to be in front of our nose. So I just wanted to, I think that is the main point of this. And I think it's important to highlight that we are looking, with this scenario of a loss of $3.8 million this year. And obviously, we're going to do whatever we can in the next 4 months to reduce that. So I think that's my presentation.
Thank you, Brad. I think just to we have a couple new members of this committee, and we have some new members of the BET. And I think it would be very helpful to just give us the lay of the land in Nathaniel Witherell. We have 202 beds. We have a memory care unit right now, correct? So if somebody could just talk about how we are set up and what it would take to effectuate the change that Brad just discussed.
So, yes, as Peter and Brad both pointed out, there's been some inflexibility, quite a bit of inflexibility as far as the structure of taking memory care.
Just outline in terms of the number of beds, 202.
Yeah, I'm sure. So, yes, we're 202 beds, but there are also other factors involved. So there's the 3rd floor, which is the designated memory care unit. And quite frankly, the 4th floor has become the unofficial memory care unit. Off the top of my head, I would say we probably have 10 out of 38 40 residents that are not really memory care or dementia right now. But that's not an official unit. And so I will get deeper into this if the time is right. I can talk a little bit more about this.
Well, I don't want to, you have a flow, and I'm happy to continue with the flow. I just wanted to sort of say you're constrained at the moment because you have a designated memory care unit. It requires, you need certain security and I
Staffing,
don't,
all of the.
I don't know what the obstacles are to.
Yeah, all of the units are secured. So that means that there are coded locks on the doors, including the memory care units. But what our plan is to get more flexible as far as the first and second floors, where we typically don't admit those memory care patients. We've not been doing that. It's been strictly the third floor. And we need to get more flexible so that we can admit to the other units.
I'm going to dumb this down a little bit, if that's okay. I've run businesses, I've bought and sold businesses, and I look at stuff, and I don't know anything about this business, and it's my first real exposure to it. Harry's tried to bring me up to speed a little bit, but you have the need for 40 more customers, and you have to go out and get those customers. And if you get those customers, you don't have as many problems as you have without those customers. Pretty much where we are. Do we advertise for more customers?
Advertise, no, not really. And that's also something that I'll get into too. It's outreach and marketing that we have to improve, and that's at the executive level, that's at the admissions level, and the clinical level.
Well, how do we get customers? And I'm sorry if I'm insensitive calling them customers. I'm just looking at it as a business. How historically have we gotten customers in this business? So, as I said, I'm not familiar with this business, but we're short customers. We need to go out and get customers. How are we historically gotten them, and how are we doing it now?
It's going out to the referral sources like Stanford Hospital and Greenwich Hospital, and quite frankly, doctors' offices, assisted living, beating the bushes, introducing ourselves, actively promoting the services that we have.
So-
Joe, let me jump in for Brad. Go ahead.
Thank you.
I
So once
think-
again, sorry again for dumbing it
No,
down.
I think the important thing here to understand is that your major referral source right now are hospitals. So obviously with Stanford and Greenwich being the nearest hospitals, those are where the biggest numbers. And actually because Stanford is bigger, we get more referrals there, but we don't get as many admissions there because it's really the patient's choice and the family's choice about where they go. And hospitals are required to give choice to the patients when they're being discharged and need long-term care. They can't say, well, go to Witherell because that's really a nice place and blah, blah, blah. They have to give choice, and so that's important. I think the other thing is that in the short term, we know that because what Brad said, we had 25 dementia patients who we rejected because they were dementia patients and our dementia beds were not available. Or in some cases, you've got we're all semi-private rooms. So we've got a male-female issue that we've got to make sure we've got, females with females, males with males, and so that complicates things a bit. But the fact of the matter is, to right to the short of it, what we're talking about right now in our plan is that we will no longer, unless it's a reason of some sort of behavioral issue, which could mean harm to the individual or other individuals, or it's a financial one where we're just going to not be reimbursed for it, we're going to make sure we admit those dementia patients. And it doesn't matter whether it's on a dementia unit or a non-dementia unit, because many nursing homes historically have not had a specialized dementia unit, but they've had a lot of dementia patients. My mother, years ago, was that way. She had dementia. She had certain problems, but the staff was trained to take care of her. So we have to make sure that with dementia being one of the biggest factors in terms of admissions to nursing homes today, that's the biggest demand right now, and it's going to get worse because individuals are living longer, and living longer doesn't always mean living healthier. And dementia is becoming a major, major issue, and we have not done what we need to do, and we're going to do it to prepare ourselves to make sure that, first of all, we can admit the patients because have had empty beds. Now, one thing just to throw in here is that we've had a pipe project going on. All of our drain pipes have had to be replaced, and it's a major, major issue, and it had to be done. And the more we replace them, the more we know it had to be done. But that's taken 12 to 16 beds out of service from April this past April of 2025. And those 12 to 16 beds, as they do them in phases, will be out of service until October or November of '27. So we have to understand that we have to be much more flexible and creative in terms of admitting those patients. Now, does it make it harder when we have those beds out of service? Of course it does. Of
course.
Because those are beds we can't move patients around in.
So,
But
so in a
that's what
way,
we're focused on.
what you had or have is a product problem where you have to change your product in order to bring in customers or to sell your product. And that's what you're saying you're doing. You're changing to a more flexible dementia product because you have demand for that, so the supply is meeting demand. Has there been in the past causing the problems that we have now, is it a combination of product problem and sales problem? Have we not gone out marketing this properly in order to bring the customers?
Well, that's part two, because I think you in a very unique manner, but for us anyway, kind of laid it out in a business way, and I appreciate that. But the fact of the matter is, no, we have not done part two. And that's something else we're focused on right now in terms of how do we make sure that our product is one that is competitive with other products, and we get that out there and we let people know it. Now, our product, from my perspective, that we need to produce is not the fanciest product. It needs to be the product that can take care of more complex long-term care patients and take care of them in a manner that they will not have to be rehospitalized. Because the worst thing, I've spent my life on the acute care side, the worst thing a hospital CEO always says, oh my God, we just got 4 long-term care readmissions on a Friday. I wonder why that is. And then they come in and they say, okay, we'll kind of patch them up a little bit and send them back again. That's not the relationship we need. So that's a major market that we have to have. Not just to hospitals, but to providers in general.
So we've identified a product problem, we've identified a sales problem, and we have now a 16-month solution to these problems. So that'll be exciting. So thank you.
Okay. All right, so, yes, there are several factors that are contributing to this, and over the past several months, we have experienced a gradual decline in the average daily census, as both Peter and Brad mentioned, from the low 170s to the mid 150s. And while that trend reflects challenges seen across the post-acute sector, we're treating it as a priority. Our turnaround plan is deliberately conservative and practical and focused on stabilization first, not rapid expansion. The objective during the first 4 to 6 months is to halt the decline and ensure referral confidence from the hospitals and other referral sources and position the facility for sustainable recovery within the constraints we currently face. Factors likely influencing the census decline, we believe the census reduction is not due to any single issue, but rather a convergence of several factors, many of which we're already addressing. As Peter mentioned, the ongoing pipe replacement project has temporarily reduced available beds by approximately 12 to 16. Beyond the physical capacity loss, projects of this particular scale can affect referral patterns, as hospitals prefer placement options with maximum flexibility. So that, again, we talk about outreach and marketing. Importantly, this project is essential infrastructure work that protects the long-term viability of the building, and we are actively managing admissions to optimize the occupancy within that reduced footprint. The memory care placement constraints, historically, memory care residents have been concentrated primarily on that one unit, and there's some leakage onto the 4th floor now. When the unit reached capacity, otherwise appropriate residents could not always be placed or accommodated elsewhere in the building. We're implementing a more flexible model that allows appropriate non-behavioral dementia residents to be safely placed on multiple units with proper support and staff training. This approach better reflects modern practices and will improve access without compromising safety. The hospital readmissions and treat-in-place practices are also important because hospitals closely monitor readmission rates when selecting post-acute partners. Even modest increases can affect their referral volume. So we're strengthening our treat-in-place capabilities, we will be, so that residents who experience clinical changes can often be managed safely on-site rather than being sent back to the hospital unnecessarily. That improves outcomes for our residents while reinforcing confidence among our referral partners. Managed care length of stay pressures, they are real. Across the industry, Medicare Advantage plans, including large insurers such as United Healthcare, are increasingly emphasizing shorter rehabilitation stays and quicker discharges, to which Brad alluded. This trend is outside the facility's direct control, but it reduces the average number of days that residents remain in post-acute care. That, in turn, affects census levels even when admissions volume remains steady. And I think you see that in the statistics that Brad shared with you. Our strategy is focusing on improving throughput and volume and maintaining strong referral resources, expanding service lines that support our stable occupancy. So the stabilization strategy for the first 4 months, our immediate focus is operational discipline and reliability, strengthening the admissions process. What that means is we're implementing a coordinated admissions approach to ensure that appropriate referrals are evaluated quickly and transitions occur smoothly. The key actions include here are 7-day admission coverage, including weekends, ensuring that real-time bed tracking updated multiple times daily, faster decision-making when clinically appropriate, and improved coordination with hospital discharge teams, as well as expanded ability to accept evening and weekend admissions. The goal is simple here. It's if a resident is appropriate for our services, we want to be ready to say yes efficiently and safely. Also ensuring referral confidence, that's executive outreach, to which I was talking before. During the first 2 months, our senior leadership, including myself, the new director of nursing services, and our medical director will be meeting directly with case management leaders and discharge planners at key hospitals, including Greenwich and Stamford. Those conversations will be focused on reaffirming our clinical capabilities, streamlining our communication channels, and clarifying admissions criteria, providing direct points of contact. In months 3 through 6, we will maintain an ongoing presence through liaison rounding at those referral sites, staff education sessions, and facility tours. Diversifying our referral sources also, while hospitals, I had mentioned before, remain critical partners for us, we're expanding our outreach to other community providers such as assisted living, home health agencies, hospice organizations, physicians' practices specializing in geriatrics and neurology, private care managers as well. That diversification will reduce our reliance on any single referral stream and support more stable long-term census. The readmission reduction initiatives, reducing avoidable hospital transfers is central for us to both quality and care and census stability. So those enhancements will include a rapid clinical assessment upon admission, early physician or nurse practitioner evaluation, close monitoring during the first week, telemedicine support when it's appropriate, expanded IV therapy and respiratory management capabilities, and strong communication with families and physicians so that we build trust. There are no panic or fewer family panic discharges, send mom out to the hospital because she might have a UTI, for example. Those measures will help residents remain safely in place whenever possible. And as previously stated, the memory care optimization, it represents one of the most stable and growing areas of need and demand during the stabilization period. We are reviewing capacity and staffing on the existing memory care unit, expanding cognitive and behavioral programming, developing referral relationships with specialists, implementing the flexible placement model across all the units, all the long-term care units. This will allow us to serve more residents without major structural changes. It's a conservative census projection, as I've said before. Our near-term projection is initially conservative and realistic. Through improvements that were directly within our control, we aim for a net increase of approximately 2 additional admissions per month during the first 4 months. If that's achieved, when it's achieved, this would move our average daily census from roughly 157 to about 165 by July, and that's a realistic target given our current bed constraints. Other initiatives, such as reduced readmissions and expanded memory care utilization, are expected to protect our existing census and support gradual growth rather than produce sudden spikes. And I will simply close by saying that our leadership and organizational strengthening, which Peter had alluded to, there are developments. We have now a new DNS, John Anantharaj, as our Director of Nursing Services. He brings extensive senior clinical leadership experience across multi-facility systems, regulatory compliance experience, and quality improvement. His focus will be on strengthening clinical consistency, staff development, and survey readiness, all of which directly influence referral confidence and resident outcomes. In addition, Zach Cecere, his role has been expanded to Technology Projects and Operations Administrator. He now coordinates cross-departmental initiatives and major facility projects. So he serves as liaison with the town and external contractors as well. This added operational capacity helps ensure that infrastructure work proceeds efficiently without disrupting resident care or admissions processes. So success by early summer, what that looks like. By the end of 4 to 6 months, we aim to achieve stabilized census trajectory, improved referral flow, conversion rate. That means converting more referrals to admissions, stronger hospital relationships, reduced avoidable readmissions, increased flexibility in memory care placement, and clear operational discipline across admissions and discharge processes. And most importantly, we expect stakeholders, including residents and families and staff and referral partners, to see a facility that is organized and responsive.
Thank you, John.
Thank you.
I think it would be helpful, and I don't know who would like to address this, but just to kind of zoom out and give us the overview of the landscape. I know we've got fewer beds in Greenwich, I believe, with Greenwich Woods converting to a residential facility. I don't know what the status is of the hospital services and whether we're getting less of our share of the pipeline or if the pipeline's reduced, or what are some of the macro factors as you see them?
I'll make a couple of comments if I can, Laura. The first comment I want to make is that I sort of think probably if I was one of the four of you sitting up there, having heard all of this from all of us, my head might be spinning. And I think the most important thing I want to say right now is that you're looking at the executive committee of the board, whether they know it or not, with one more addition, and that would be Peggy Martino, who is a board member who's also a very accomplished retired nurse. And so with operations, with finance, with legal and compliance, and with the quality side with Peggy, our intention is, my intention is now our intention, is to make sure that everything that you hear, and there's a lot of stuff, the bottom line is that we will be meeting on a regular basis, not just board meetings, but this committee will be meeting with John and his staff to make sure that everything that we have presented is actually going to come to fruition, because at the end of the day, the most important thing is the census. Now, to answer your question, people are still getting sick. Hospitals, for the most part, I mean, the hospitals I ran before I retired, we were always full. We were always full. The issue with hospital referrals to long-term care is referrals to come. I'll give you an example. Stanford might refer in a month. We may get 60 to 70 referrals from the hospital of patients that are being discharged. of those 60 or 70 referrals, how many admissions do they come to? 8, 10, maybe, although in Stanford's case, the referrals and the consequent admissions are going up. And in Greenwich's, but just smaller, their referrals have gone down and the admissions have gone down. So we have to address that. Now, we met with the hospital leadership at Stanford when we weren't getting much of anything when I first got on the board, because I have a close relationship with the CEO there. And that's resulted in an uptick. We have to do the same thing with Greenwich. We have to do the same thing with Norwalk Hospital in Norwalk. We have to do the same thing with White Plains Hospital in White Plains, because we get referrals from there. And, you know, we had hoped that we had an opportunity to do a program with Burke Rehab Hospital in White Plains. They responded to the RFP for physical therapy services, which we put out last year. And after being awarded the RFP to do it, for some reason, which is still unclear to us, they decided they could not do it and pulled out. That does not mean that they don't refer patients to long-term care and we have to go to them. So the marketplace, in my estimation, is there, but it's a competitive marketplace because nursing homes are closing in many cases because financial reasons, and Medicare, or Medicaid rather, is a concern over the next year in terms of what's going to happen with nursing home reimbursement on the Medicaid side. But the fact of the matter is, from my perspective, having spent my career on the acute care side, there are the patients out there. We have to Joe's point, we have to go after them. And that's what we're going to do. So I don't think there's a lack. If you're talking about 70, or even from Greenwich, 30 or 40 referrals, and we're converting 10 or 12 of those to admissions, where are the other ones going? Particularly with some nursing homes who are in financial trouble and closing. So the population is out there. There's no reason why we can't get the census up the way that we're proposing.
Yeah, and just let me also mention, because Laura, you talked about the macro, and this doesn't get much more macro, which is CMS, all of the managed care organizations, those insurers are chosen by CMS. CMS does this by design: lower the average length of stay, get patients in, get them out as quickly as possible. So they aggressively do that, and that's why you're seeing a lot more of the churn in short term. But we've got to adapt to that, like every other place does. It's not an excuse. We need to adapt to that and change our strategies. But that it is a huge factor in our short-term churn. And I'll give you a really quick example of that. We literally at Morning Report this morning, we had 8 discharges from the facility, all managed care. So it goes very quickly, and you've got to try to backfill as quickly as possible.
I want to recognize Harry, who along with Stephen Selps has been the BET liaison to Nathaniel Witherell, attending board meetings and finance committee meetings. So Harry, I don't know if you want to open us up
Sure.
and.
I'll just focus on what you just said. You lost 8 today.
Yes,
So what's the census standout today?
it was 159, so it's 151 today.
Okay. Staying on the topic of census, you're trying to get, up to the high or the mid 160s, in this fiscal year. You've got in the budget for fiscal 27 a target of average of 175. So by the end of fiscal 27, you're going to have to be up around 180 at least to get an average of 175. Simple math. Does your plan recognize that you need to get to that level, and is that achievable?
I think we understand we have to get to that level, Harry. Being achievable, the challenge we have, and I'm not saying we can't do it, the challenge we have is that the beds that we have available, we have enough beds. We're not going out looking for more beds to be certified. We're looking for the maximum number of beds that we have to be able to be utilized. So one of the challenges that we have, the big one right now, is this pipe project. If we can, we're doing everything we can to accelerate that, but you can only accelerate so quickly. So are we being conservative? The answer is probably yes. Can we get more? I would hope so, but, hope doesn't get you very far. It never got me any, big Christmas present. So, I don't want to hope. I want to be practical and be transparent on what we think we can do. Obviously, this 4-month period we have to the rest of this year is going to be very telling in terms of where we can go in the 27 budget. So if we can be as successful as possible and go and convert those referrals that we know are out there into admissions, we can get more if we have the capability to actually admit them, and that's going to be the challenge.
Yeah, I guess that heads towards, somewhat of another question I had is, at what point should we be expecting to measure success? And then you're just mentioning a 4-month checkpoint, the end of the fiscal year 26, I guess, to see what sort of progress has been made. And I'm encouraged to think along those lines.
Which, by the way, that is why we're doing it now.
Right.
To have 4 full months, I would be optimistic, again, I'm not hopeful, optimistic, that we can demonstrate that what Brad laid out in terms of what we want to do and in terms of 2 additional months, that can be a bellwether in terms of where we think we can go, and if necessary, come back to the BET and revisit the 27 budget. But until we can have some sense that we can sit before you with a straight face and say, this is possible. So this 4-month period is going to be incredibly important. And I can tell you from our perspective, this is not going to be something that we're going to spend a lot of time trying to convince people this is the right thing to do. We have to make sure that the people we depend on, and that's our staff, understand that this is a mutual challenge for all of us. If we're successful, we all succeed. And I'm not even talking about if we fail, we all fail, because we need to be successful. So just to, expand on your point.
Yeah, I mean, a few years back, there was a request for a proposal. There were a number of proposals came back for a different model of managing the facility. It didn't get passed. It didn't move forward. And I think that's really because the board at the time was not interested in moving it forward. And we are at a bit of a disadvantage from our standpoint on the BET, that the town attorney has indicated that any alternative has to originate with the board, whatever that alternative may be. And I'm not an expert in the industry. I just know what was presented previously. But the losses to the town, moderated a little bit in the 23-24 period. But, now it's, as we know, it's a revenue problem. You've done a good job in the first 6 months of the fiscal year controlling expenses to the extent of a $388,000 positive variance, which is good to see. But, this is the question that comes up at me from all parts of town. How long are we going to tolerate this? And I think the tolerance level is getting really thin, both on the board and among the general public that at least talk to me. So, my question is unanswerable, but at some point, I think we need to sit down and really have a serious conversation about, again, looking at alternatives. Because I also hear that ours is not a localized problem. The industry, I gather, and talking to Joan, talking to the state, the industry has a problem, and it's similar to ours. we don't have the economies of scale with this facility. Whether there's economies of scale that would affect both revenue and costs, one should expect that if we had a bigger scale of, an operating company or whatever the model is. So I just, say that that's my perspective. I think it's shared by a lot of people on the board. And, I think if we're going to look at it in 4 months, then, that's going to be a real indicator of whether or not this plan has a chance of succeeding. Because, at 151, I'm not sure that that facility's ever been that low.
Well, if I could make a couple of comments
Please.
to respond to what you're saying. I think a couple of things, and I agree with you. I think that just as whether there were hospital mergers and affiliations and systems were formed going back, starting in the 80s up until now and accelerated, there's those discussions going on nationally with long-term care systems. And I read a very interesting article the other day in terms of what makes a independent facility attractive to potentially being part of a larger system. And one of the biggest things is the facility. I will tell you right now, a system would come in and look at Witherell and say, oh, great, you're just spending a whole bunch of money on pipes. That's good. What else is wrong with the place? How attractive it is. So we have to make ourselves, if we want to pursue that, and I don't disagree with it. I'm not a fan of for-profit systems taking over nursing homes because I've seen what happens in those situations. But, are there systems? Are there hospital systems? That's come up too. Does a hospital system have an interest in being part of a nursing home, being part of it? That's a really big question. I actually have a meeting with Kathy Szilard over in Stanford just because I've been retired now for 3 years, so I don't know totally what the pulse is in terms of acute care and long-term relationships, and I want to pick her brain about that because for two reasons. One, how do we get more referrals and therefore admissions from you, but also to understand what's the environment out there in terms of an appetite on any basis to do something with a independent facility like Witherell. I will tell you my opinion is that we have to make it more attractive under any circumstances that we're talking about now. But certainly, I think the fact that the amount of capital, and I'm just saying this because it's my observation, having been in the business for so long, the amount of deferred maintenance that's taken place at Witherell over the years, from my perspective, and the pipes are just one glaring example. You all saw the pictures that we showed. That doesn't bode well for us being attracted to have a relationship, if we're looking for a financial relationship with another provider or system, maybe an affiliation where they'd get our residents, we get their patients, but we have work to do in collaboration. We have the work to do, and I think to make sure that from the physical standpoint, the facility is something that somebody's going to not walk in and say, no, come back to us when you got this fixed up. So there's challenges on both sides.
Yeah, and I appreciate that. I would suggest that, in return for operational improvements, and, over the last 12 years, the margin before debt and capital has averaged about $2.1 million loss. So, if we could look at operational improvements and make a commitment to capital investments, that might be something we would consider as a way to get that process going earlier. And, I don't know if that's a reasonable plan or not, but it's, and after debt and capital, the loss, before the town and other contributions over the last 12 years is close to $5 million. So these are huge numbers. And as you've heard me say, you could have built a school for that.
Yeah.
And, we need to find our way out of this hole. So I'm encouraged you've got a new plan. And, I look forward to hearing about it in the next few months.
Well, we certainly don't plan on trying to dig ourselves out of the hole, so we want to climb out of it, so I agree with you.
Okay, I agree with
I
that.
agree with you.
So Harry, I think you're referring to the history. I think Joan updated it recently when she was working from her generator at home yesterday.
Yeah.
If you could just make sure everyone gets that on the
They'll
PDP.
distribute it. Intentionally wanted to distribute it after because the Nathaniel Witherell team hasn't seen it.
Yes,
so-
of course, and they
Yeah.
should absolutely see it. If I could just, and Joe, I know you had a question, but I kind of want to level set because a few years ago, well, after COVID, during COVID, we had the challenges of COVID. We had some challenges with collecting accounts receivable. Yeah, we've had some challenges with staffing. So if we could just sort of say where we are in terms of some of the things that we've addressed. I think another one of the challenges is that we weren't always appropriately billing for services rendered. And I think you went through an auditing process, and I think we're much more on top of that. So I want to talk about, Brad had talked about before the long-term care beds have fallen. Memory care is an easy place, not an easy place, but a piece that it's logical to pick up some beds. But it's also the place where they're largely Medicaid composed. So I want to talk about the payer census as well, not just the census. But the profitability of those short-term beds, even if they have a shorter length of stay, it's still a profitable business, is it not? I mean, I threw a lot out there. It's
It
kind of
is,
like
no.
where we've been, where we've gone, and sort of a little bit deeper understanding about short-term, long-term.
So short-term, which is primarily Medicare, we have made great strides in the per-day rate, Medicare rate. We were below our peer average for quite some time. That had to do with the MDS, which is a resident assessment tool, and from that tool, what's documented in it, that drives patient care and subsequent reimbursement for that care. And so the coding and diagnoses on that assessment, we needed to get much better, more accurate. We've addressed that, and the end result of that is going from, I would say, an average of about 675 per day to just over 800 per day. So that made a huge difference. We also found some coding errors from the state and federal side recently that also that represents about $72,000 in additional revenue just by correcting that mistake with the state and the feds. Medicaid, as Brad said, Medicaid loses, no matter how much the rate is, it always pays less than what the care provided is, right? So just as an example, if we're in the 4 and change range per day, it costs about $100 to $150 more per day to take care of that resident. And we've got 156 Medicaid beds. We've got 46 short-term beds.
And then on the receivables, do you want to just touch on what we've done there to ensure timely collection of receivables and adequate debt reserves?
Our receivable has been great. So we have a outside agency, so we have been monitoring the collections compared to the industry benchmark. We have been collecting 98 to 99% collectible every month. So that would be reported for our monthly financial report.
The one thing I just wanted to add, and this is my own perspective, is that a lot of the improvements that you're talking about, they're internal. They're internal. They're not get the patients. Yeah, we got to get them too. But most of the improvements are internal. It should be under our control. And sometimes it's easier said than done. So that is, to me, that's encouraging in a way because we should be able to solve our own problem. That will in itself improve some of the outcomes. And then, yes, of course, we need more. But a lot of what we're talking about is internal improvements and how quickly that can be done, and with, what kind of management leadership we need, that's going to determine the short-term period.
So in terms of more acute care capability, I know the question has been raised, if we're adding more serious, or patients who require more care, what does that do to our staffing model? Can that be addressed?
I don't think, and I'll defer to John for further comments. I don't think it's going to change our model. I think it's going to change the appropriate training and orientation our staff get, primarily nurses, to be able to handle these things. Now, example is the COPD program, the chronic obstructive pulmonary disease program that we started less than a year ago, right, John? And that came about because when we met with Stanford Hospital, they said, we have a big inpatient program, we need someplace to send patients on a long-term care side. And actually, a few doctors from the hospital there work with us to develop that program. So, and then the nurses are trained. It's not, we're not going to be taking care of any level of patients that is beyond what the normal capability should be, unless there is some reason that we should bring more specialized nurses in, which will cost more. For service, it may cost more, but there needs to be a bottom line positive margin if we do that. But I think certain things, just IVs, placing IVs, a lot of hospitals, nursing homes say, we'll take a patient on IV, but we won't place an IV. You've got to place it there. These are the kinds of care that nurses have been trained to do and can be trained to do and are appropriate to be trained for. So I don't think we're looking at a hugely different staff model. I think we're looking at the fact of having more of our staff appropriately trained and appropriately capable of taking care of a variety of different more acute services that hospitals are looking for long-term care facilities to provide, because they see it as inappropriate to do in the hospital any longer.
Joe, did you have a question?
Yes. I served 4 years on the Board of Education, and it was during a time when we had declining student enrollments. And a lot of the plans going forward, the projections going forward, were based on keeping things as they were. The argument was, if you have 25 kids to a class and you reduce it, if the student enrollment declines and you go to 22, 21 kids to a class, you keep the structure in place for when that trend changes. I would always insist on what happens if bad stuff happens and we go below, much more below where we are now. I'd like a plan for that, and I never got one. I was very disappointed, and I learned that lesson serving. Here we are in a situation where you're talking about, we have 151 headcount right now. You're saying that we're projections in the next 16 months are to grow to 180-something headcount? Is that what we said? 160? Sorry, I didn't.
160, 165. by
165,
July,
so a growth trend. And if your plan, and which of course we all hope it does, if that plan doesn't work, what if we're around 130, 125 patients in the near future? Do we have a plan? Do we have a stop loss? Do we have something? And if you don't, that's fine. But I personally would like to hear, or at least consider, what suggestions to us or to the town, what we would take, what we do if we reach a certain benchmark. So I guess you don't have a plan for that. I don't think you would. I would. But please, I would like to hear some plan like that.
Yeah, and I think that's a very reasonable request, because again, on the acute care side, we always face the same thing. You always want to make sure that you're prepared, because you can get a spike in admissions and all of a sudden you got more than you can handle. But to your point, and I've seen it in that industry, that there does become a point where you have to trim and say, okay, if it suddenly goes up again, you might have to bring outside help in. But I think we have to do that, and I would say that Brad would probably agree with that, I think.
I think so, yes.
Thank you.
Elliot, you had a question?
Yeah, thank you. I actually have two questions. And first off, I apologize. I am way out of my comfort zone when it comes to talking about healthcare in general. So I apologize if some of these questions are naive. Two questions. First, I want to understand the cost structure a little more when it comes to delivering dementia-related services. And then the other question is, I understand that you evidently have the demand for dementia patients, but I don't understand why you were turning down the requests that you had. Maybe you mentioned that, and I just missed it.
I think, Elliot, that the issue was, and I'll just be very blunt about it, I think we had grown complacent. We said we have 20, X number of beds for dementia patients, they're full, we can't take any more. And that's the regrettable but best answer I can give you, and we can't afford to be complacent. We never should have been, and we're not going to be now. Because again, with the dementia patients we're talking about, we're not talking about somebody who is an uncontrollable dementia patient. We're not talking about dementia patients who, strikes out and, hits other patients and staff. We're talking about patients, and, many, I don't know if any of us in the room, but I have experienced that a lot of times the difficult part of a dementia patient is just guiding them to where they have to be and making sure you're keeping them safe. So those are the patients that we're looking for. Our staff are capable of handling them. Will we have to make some modest accommodations, perhaps in terms of units, and so that these patients can't go places that they shouldn't be? We might have to lock certain doors, et cetera, but that's kind of a normal thing to do. So we're not talking about a tremendous increase in the ability of our clinical staff, and not just the nurses, but also the nurses' assistants to help handle these patients. I'm not sure if that's a good answer to you, but whenever I heard somebody say that, I'm kind of ignorant to this, but I'm going to ask you a naive question. I think about Sam Ervin in the old Watergate days, and I'm just a country lawyer, but let me ask you a question. So I'm trying to give you the right answer.
And what about the cost structure for treating dementia patients? Is it higher than the delivery of other services?
It is higher, and so again, the Medicaid rate doesn't cover. It doesn't fully cover the daily cost of care, especially for dementia and memory care patients. Again, you're really talking about losing $200 a day, every day, when you're providing that care.
So I'm sorry. What am I missing then? I mean, it sounds like I'm not understanding something here. I mean, it sounds like you're recommending us to go deeper into the dementia business, for lack of a better word, but we're going to lose more money with more volume?
But not on every case. There are Medicare cases that are dementia cases and memory care cases. There are also, depending on the acuity, that rate can go up. So, and it will go up. So there's money to be made on those dementia care and memory patients. It's getting the mix right, getting the ones that are high acuity, not necessarily high care, but high acuity, and will actually make more money on the Medicare and even the Medicaid rate on some of those higher acuity Medicare and Medicaid dementia patients.
Elliot, let me just add, nobody is going to take patients right now that are going to lose money. We're not going to do that. We have capacity. We have enormous excess capacity. We have staff to 5-star levels. We've got more staff than we've ever had. So adding any kind of patient right now is accretive to revenues and earnings. We have capacity up to, I don't know, John can tell you what we have capacity maybe to 180 patients. We've already staffed for that. So Incremental revenues are going to drop the bottom line. And yes, obviously, you're right. We want to be careful how many Medicaid patients we take. But right now, I mean, we lost 8, we can take 8 back and just get back to where we were with the same payer base.
Yeah, I mean, you have high fixed costs, so you're just getting you're spreading that over more beds.
Like an airplane, like an airplane, you know.
John, that's something you wanted to say.
Yeah.
That's what I was going to say, is just to help Elliot, just the absorption of the fixed costs. It's a very large amount of the costs at the facility are fixed. The variable are basically the lower level nursing assistants. Those are variable. But around that, it's very largely fixed.
So before I take additional questions, I just want to talk about how I want to approach this. And I will say this is a budget conversation, but I think this is a longer conversation that will take place over the course of the next several months as you implement your plan and as we have checkpoints and figure out where we are. And I think we can all appreciate that. Nathaniel Witherell is in its own fund. I do want to make sure we have time to go through the expenses themselves. We could have we could spend a long time talking about the macro trends in the industry, and we can do that. But I think at the end of the day, we also want to understand the budget as it is presented before us, and also understand the risks to that budget. So if there are general questions, happy to take them, but we are going to get into the actual expense codes. So David and then Leslie. Microphone for David, please. Or maybe we'll go Leslie and then David. How's that?
So this may actually be a specific question, because I too want to understand what we're being asked to approve. In our budget book, under staffing, there's 148 full-time employees, and I've heard the number 151, but that's certainly not in my book. And the other thing,
Leslie, that's census. That's today's census, 151.
Oh, yes, census, we know. Okay, fine. So we're at 148, and that's fine. But also, in here is the part-time, FTEs, and that increases by 4.1, and yet I haven't heard anything about a change in that, but I also don't see Witherell coming to the HR committee tomorrow, so I would like a clarification on this, as well as going through the details as you're suggesting, Laura. Thank you.
So we'll get to the TOO after we go through the expense items.
So, Peter, Joe Kelly asked a good question, which I get a lot from people in the community, and that is, if you're only at 150, 51 census, why don't we run the facility to address the numbers of patients that we have? And I think Joan Lynch may have answered it, but I think it may be worth reinforcing that, and that is that the high level of fixed expenses involved in this, fixed costs involved here, may preclude that as being a strategy. I mean, I saw it, Peter, you made an aside to Brad and said, let's do a little work on that, and that's good. I think Joe's asking a question that I get a lot of people asking me. Joe Kelly's asking the same question. But is it the case, or is it your intuition that reducing the size of the facility or the number of beds wouldn't really address the fundamental loss that we're dealing with? I don't want to put words in your mouth, but you have a sense of that.
Yeah, David, I mean, this is a good question, but we really have not spent time thinking through those scenarios. I think the goal has been to staff at a high service level so that we can accommodate more patients and be a more attractive partner to this enormously important hospital network, referral network. They like to see 5 stars. They'll send more people when there's 5 stars. They'll send more people if they have more services like COPD and IV hydration. That it was the concept, because we need to grow to save ourselves, right? We need to grow. So scaling back the effort on the staffing was not consistent with that outlook. We may have to rethink that, but at this point, we've been thinking to grow ourselves into a better position, not to scale everything back and just hunker down.
Thank you, Brad. I also just want to point out, I don't think it's a unilateral decision, right? It's a highly regulated industry. You would have to go apply through the state for a reduction in beds. Is that not correct?
Yes, you'd have to do letters of intent to the DSS and the DPH. You'd have to do CONs as well. You'd have to have that approved through not only the state, but the federal governments.
So I'm not discounting that as an ultimate avenue, but I think it's something that you guys should look into. It's just, I don't think it's as easy as snapping your fingers and making a decision to shut down a unit or a floor.
No, it's absolutely not. I mean, and again, I spent my career on the New York healthcare side, and I have seen health departments spend tens of millions of dollars keeping a hospital that should close open, only to have it close eventually. But the point being is that when you start taking healthcare services away, and look, long-term care is something that there's a greater need for, not a lesser need for. The problem is that from a reimbursement standpoint, the third parties have not really caught up with it. In fact, they're looking at saying, how do I save money? And long-term care kind of gets hit first. But I think that the plan that we have over the next 16 months should be a very important guidepost in terms of in what direction should we go. We know that there's a need out there right now.
Okay.
Just one last, and I know you're running behind. I'll be brief in the question, I hope. This is a dynamic I think we should, in the course of this budget year, put to bed. Do we shrink ourselves possibly into oblivion, or maybe we get some savings, or do we try to, as Brad said, grow to achieve the capacity that we have? I will say, and this is a question, that when looking at the referral program, Peter, that you initiated, it seems to have been quite successful. In other words, if I look at the Stanford Hospital referral number, say the first month of July 2025, you had 46 referrals. It's now gone to 64 in the most recent month. The really highlighted number here, however, is the abysmal acceptance rate, which is it's like only 12 of the 64 that we offered beds to accepted it. So I know that data can be mined as to the reasons why we get maybe that's typical for the referrals, maybe that's an aberration, but your referral concept in partnership with Stanford seems to have borne some fruit. It seems to be quite good, but that the acceptance has been very disappointing, as you guys have pointed out.
And that's really based on two things, I think, David. One is family choice. In many cases, in fairness, Stanford, a lot of patients, or even Norwalk, are not coming from close to Greenwich, and they want to be, the families want to be close to the family. So we have to be more attractive for clinical reasons, for environmental reasons to do that. And I think that's one of the challenges that we have. But the referrals are there. To your point, we've just got to mine them.
Thank you. Okay, I think Leslie Tarkington asked a very good question, which is, what are we here to do today? And I think what we all need to understand is we actually appropriate the expenses, both operating and capital. And then our role is to look at the fund balance. And historically, we have been funding the losses in the fund balance in arrears. This year, we have $2 million projected to fund a prior year loss. But I think we all want to get a better sense of that number and where it comes from and the trends and what we should be doing from a budgeting perspective to be responsible. Historically, the town had budgeted a town contribution in the budget. It went from, I believe, 3 million to 1.5 to 500,000 to 0. So now we're fully funding in arrears. But I think we want to look at the actual expenditures, including capital, and then just kind of look at the trends in fund balance. So I think that's our role here today. I will say, as someone who had been a liaison to Nathaniel Witherell in the past when I was on the BET and on the RTM and part of one of the many project committees that have been formed over the last few years, this is a complicated business. So anyone who is looking at this for the first time, whether you're on the RTM or the BET or just a member of the public, it is a daunting business to understand and follow. So I do commend everyone who's following it. I commend the board members who have really rolled up their sleeves. You've completely revamped the board structure. You're doing a lot more work at committee levels, making your board meetings much more productive. So there's a lot of work that's gone into that. And I look at the finance committee alone. So it's really impressive. So, kudos to you all. But if we could turn to our budget book, it's a people business, and your trends in overtime and temporary salaries, your regular salaries seem to be in line, but there are significant increases here in both overtime and temporary salaries. And Kelly or John, I don't know if you explain to us what's going on here.
Hi, Laura. So yes, we do encounter extra overtime due to the recent weather. So when we budgeted, and we also created a strategy since April 2025 to hire more part-time employees to offset the overtime expenditures. So it has been working offset the overtime, but we are in the people business, and we will control the overtime and personnel budget. So, and looking at the fiscal 2027 budget, according to the contract, and our increase is around 3%, and I think that's a very conservative and reasonable increase for nursing, which is our biggest department for the whole facility, for fiscal 2027 budget.
So are we using outside agencies for nursing coverage? You have not.
We have not actually successfully, the last 4 months, we have zero agency cost. And
Okay.
at one time, it was over 100,000, so we successfully reduced that agency cost.
Any additional questions? I mean, it's a big number, those two line items, big increases. The other one that jumps out at me in the 200s is the telephone. What's happening there?
Unfortunately, in our neighborhood, the reception at tower is not that good, so we do had external services and software to increase because we're in the service or hospital or nursing home, so having a proper connection for the telephone for emergency calls, they are very important. And for family members, try to reach out their loved ones. So it's necessary. It's not, we just randomly want to increase costs in the connection and communication sector.
Harry?
I'm trying to understand that. Are you trying to enhance the cell service there?
Correct.
Mechanically, how are you doing that?
So get back to the technical point, I don't have the, maybe John can, with the IT background, can have.
So off the top of my head, I will tell you that I know that there is a communication, an added communication, they'll call it a ring, that was added to the telecommunications network to improve service across the whole facility. I don't know the cost of that, but yes, to that point, we did experience where we are sort of in this rural no man's land, real problems constricting with service, cell service, and regular service as well. So that's.
There are devices you can put in to, connect your cell phones to the wireless network, and your internet service.
Yeah, but there's
Got it.
only so much capacity on the wireless network that if everybody who goes in is connecting to the wireless network, it doesn't work.
And we had requested a cell tower.
I remember that.
Which we
The neighbors turned down.
They did turn it down. I thought originally they turned it down just because they thought it would be unsightly. There were renderings of it, and it actually looked pretty attractive, but it turns out, from what I had heard, it was more a concern over
Radiation.
Yes, exactly. But that would help us a great deal. I think there are other ways that we could do it. But again, it's the cell service has been incredibly unreliable. And I would like to explore that because it would actually generate income with companies like Verizon, AT&T. It would generate monthly income
Yeah, I
for
know.
us.
Yeah, neighbors have poor service too. So if there's a solution that can work for the area, that would be helpful.
Right.
Can we just drill down into this a little bit and find out if it's a booster or if it's,
Sure.
if this is an operating item or something that should be capitalized or a short-term solution or a long-term solution? I'm with Harry. I don't understand the logistics of how this is happening. I appreciate it's a problem that needs to be solved. I just would like to get a better understanding.
Sure.
Then the next item I have in 300s is food. I know food and quality of food is a big deal. You have an increase here, and maybe it's related to Leslie's question about the TOO for food service workers part-time, but let's talk about what's going on there.
So the overall dietary, it does look like a big increase compared to the fiscal 2027 budget, but compared to the actual cost for the dietary for fiscal 2025, we actually reduced $50,000. It's $50,703 less than the actual dietary cost for the entire dietary total cost. So we're working with our vendor, our team, and we set up some KPI. We have monthly or weekly meeting with John and the new director of the food services to cut down costs and how we can maintain good quality in the dietary and reduce costs.
And we're also working with METZ, M-E-T-Z, which is our outsourced food vendor. I had a meeting with them 2 weeks ago to talk about how we can reduce some of the staff right now. I don't want to get into those positions, but there seems to be a pathway forward to reducing some of the staff without decreasing quality of service. So I will have more to come on that in the coming weeks, but yes, we are seriously looking at some staff reductions in that area.
And I think it was the tray line project, and I can't remember where that stands, if it's completed, and
It is completed.
Finished, and did it do what you wanted it to do?
it-
And
it-
remind me what it was.
It was reducing FTEs by 1.5, which it did. But I believe that, if I'm thinking off the top of my head, the budget was supposed to be 16.5 FTEs, and there's absolutely no way that you can run that service with 16.5 FTEs. It's typically about 21 to provide the service, just your basic service. So that's something else, again, where I want to look at where we can responsibly reduce and still provide the service. So I will have more information on that.
You're
It's
right,
in-
John,
in
and also our
development.
facility operates 7 days a week, not 5 days.
Right, and there are a lot of dietary restrictions. I
Right.
mean, as I recall, this is one of the issues that Family Council has brought up repeatedly, and the tray line was meant to deliver the food more expeditiously and have it served hot, not lukewarm or cold.
Right,
Is that right?
Yes.
that's right.
That's, after some bumps, yes, that's, the service has been at the 90 to 95% level of efficiency, of temperature, cold, hot, et cetera, where it's supposed to be.
So in terms of the part-time equivalent positions for food service workers, I know it's a combination between our outsourced vendor and our own employees, so you'll give us an update on what the expected model will be? Are you actually asking for an increase from 4.5 to 8.6?
No, I'm not asking for that.
You're not? Okay,
No.
maybe you can give us an updated TOO then. That would be
Yes,
helpful.
I can, I will.
Okay, great.
Can I just, one quick question, 52220, electric service, just why is it up 40% from the 25 actual of 412,000 to almost 580 in 2 years?
Sorry, what number was that?
Electric service.
Electric service, 52220.
Kelly,
You can also
yeah,
come
you can
back
get
to
back
us
to us,
later, you
Kelly.
don't need to.
So when we were preparing for the budget in October was based on the July to August actual invoices. So at that point, we annualized it at 554,000 at that level. So that was current compared to the fiscal year 2027. So at that time, it was based on the current expenditure at the time.
But that would be air conditioning season, would it not? Wouldn't you want to look at a seasonal run
Yeah,
rate?
now looking back, yeah, you're correct.
So is that, can we relook at that number to see if if that can be adjusted?
Sure.
That work for you? Okay. The other one I had, I think, was on the 400 accounts, just the maintenance of building supplies. Well, actually, the maintenance in general, and some of this I know is fluctuating, but it's going up by 17.6%. And that's a little higher than what we've seen in other departments. I know there's continuous needs, but is there something going on there?
So the Department of Maintenance and Plant, so they have been telling me that the department has always have been under budget. So look through the expenditures and even with the pipe project, we outsource for labor to prepare that our staff still have to supervise and monitor them. So with the major and every cost of the building is the old structure. So giving that extra 400,000, it is actually very reasonable in the big cost of the total 21 million cost. It's a fraction of the total expenditure.
Laura, understanding that part of the reason that, or the pipe project falls under maintenance and supervision, and I am more than happy to take a deep dive into looking at those based on what we learned the hard way in terms of the pipe project. So I'm not sure who put that together and when, but let us look at that again, because that's a concern to me also.
I mean, I think it's a fair point that those line items have probably been under budgeted over the years based on what you're seeing and some of the capital projects that you're doing as a result. But it's, it's just something that if we could have a better understanding of, that would be helpful.
Sure.
And then the remaining codes are really all the fringe benefits that the town provides those numbers. So I don't know if anyone has any other specific questions on operating expenses. We can move to capital. I'm not trying to rush anybody, but I do recognize that you're coming before us tonight for an interim. We have a meeting at 6:30, so
Sorry.
go ahead, Doug.
Can I just go, actually, I want to go a page back or just go to revenue. And I guess in the plan you provided, you have an estimate for FY '26. But I guess in your 16-month plan, is the last 12 months consistent with what was presented as the budget?
Do you mean cost-wise?
Cost and revenue-wise, I guess,
So
revenue and cost-wise.
for the, so the time that when we were presenting and structured the budget, in October 2025, we did an average of 172 census. So at the time, we're projecting 175. It was very reasonable and supportive. In terms of cost, as you see the past 6 months, from July to December, we control our costs very well. It's actually under budget. So cost-wise, we continue to monitor it and work our best we can. But unfortunately, now, certain thing is very dynamic, and we try our best to control it.
That's what I referred to earlier, when through 6 months, they've got a positive variance on expenses of 388,000.
No,
But I think the point
the
is,
problem-
the point is we
the
have to
problem is
keep
the
looking
revenue
at
side.
fund balance. And that's, I think, we've recognized the point, the run rate versus the budget. The budget is, it's a risky budget based on the run rate. So we're going to have to keep monitoring it. But we don't change the revenue. We allocate the expenses.
got it.
That's right.
Okay, let's go to capital. The first item is ceiling replacement in resident rooms. 735. Harry, I think you had a question on this.
Yeah, this is, Peter, you and I spoke of this last weekend. Can you talk a little bit about the priority on this? I know it's only 81 rooms, but it happens to tie into what the interim is this evening. So could you talk a little bit about how much of a priority, what does this really impact? What's driving the equation here?
Well, part of the reason that we started that plan was because it's the precursor to also upgrading the call bell system. So part of the call bell systems on all of the nursing floors in the tower are, it's antiquated, they're obsolete, very difficult, if not impossible, to get repair parts for them any longer. And so dropping the ceilings, instead of doing wire chases, we can run everything through a drop ceiling, and that would set us up really well for each call bell system. We wanted to be conservative as far as possibly phasing it in. There is the possibility to phase it in per floor, and then follow with the call bell system per floor. That's something that we talked about, Harry, after our previous meeting, and you made that comment.
I think, if I could, Harry, is this a project that absolutely has to happen? Could we do the call bell system without the drop ceiling? The answer probably is yes. It's really an issue if I'm a resident, and this is my home, and I'm looking up every day and I'm seeing all these things hanging on the ceiling. What are they? So, but where I'm going with this is, and I said this to you when you and I talked on the phone the other day, is that certainly this is something that we can take, the board, next board meeting is in March, and I'm certainly willing to go back and review that in terms of understanding the BET's concern about the expense that ideally is hopefully this time about to be approved tonight, and is there an offset? So we can look at that. I'm not going to commit anything other than to really look at it and understand what the impact would be, but it is something we can look at
And
clearly.
help me understand a little bit of logistics. Only 81 rooms, you don't have to do the other 120 odd?
I'm not sure why. Why is it stated as 80 room, John? I don't have a good answer to that.
Yeah, I think just some of the ceilings have already been dropped in certain rooms, and these would be the remaining.
And the call bell system has a, projected 130 in each of 4 years, starting fiscal 28.
Yes, sir.
You wouldn't want to run this somewhat coincidentally?
Well, my point was, if we needed to be flexible, we could do it, so you drop the ceilings, and then you bring in the call bell company, whichever company it was, and they would do all of the runs. It's usually daisy chained through the ceilings, but they'd have to have the drop ceilings in first in order to do that work,
Okay.
But I
rather than
I think
a
what
cable
we're-
chase.
I think what we're asking you is go back and take a look at how to phase this project, and
Sure.
whether it's, I think of the old Rob
Well,
Reiner
I'm
skit, is
sorry.
it sock shoe or whatever, but do we do ceiling and call bell, or all ceilings and then all call bells? What's the best way to?
I'm
this
thinking the
project.
former right now, but I'll definitely get back to you on what we think is the best plan.
Yeah, if you could,
Sure,
we'd appreciate it.
of course.
And also we'll look at the technology behind call bells, because again, I'm very aware of them, and that technology changes by the minute. I'm not sure if what we're thinking about in terms of the call bell system is one that could not be more flexible. I don't know that, but we can look at that whole project. I
Okay.
agree.
Thank you.
And if you're taking a room out of service for the pipe project, and it makes sense to do the drop ceiling project at the same time, I mean, that's another, you wouldn't want to get a room back online from completing the pipe project and then take it out of commission because of the ceiling, although I'm sure it's hopefully a less amount of time.
It definitely was a less amount of time, but fair point.
Okay, so just for expectations, we have a decision day next week. I don't know if we'll get the information before then, but certainly before the full BET decision day, we'd appreciate that careful look through and response. Fair?
Yep.
Kitchen A2 replacement, air handling unit, 50 years old. I guess it's time for a new one?
Yes, and so there really is no effective air conditioning in the kitchen. They're using wall fans and standalone fans as well, which is not ideal, especially just for food prep, as you can imagine, and infection control. And it's also not really conducive to folks that are working in a hot kitchen preparing food and then having to leave the doors and windows open. You can see the reasoning behind it. It does really make perfect sense to me.
So is there a central chiller for the whole facility?
Yes.
Okay.
Next item, kitchen ceiling renovations.
Yes, the kitchen ceiling renovations, they're metal tile, and they're rusting, all of them. So it runs the expanse, all the square footage in the ceiling on the kitchen, and we would replace those with, a standard construction material that it certainly wouldn't be metal.
Well, hang on, because this looks like you are renovating the metal.
Oh.
Sorry, so
That's
just-
because it was cheaper. That's right. I'm sorry. It was less money to replace. So they would sand down and replace the tiles that they could replace, and then do a special coating and paint on the existing tiles. That's right.
Is this going to require more maintenance versus the option to replace?
Not from what I've heard from the companies, the construction, and the staff. No.
Okay, so this will extend the useful life for,
Yes.
okay. And the last item, the storage area renovations for $50,000.
Yes, so storage is really at a premium, and oftentimes what happens is we rent a few pods and put them outside. Not really ideal, and it's more difficult to, it's unsightly because it looks kind of crummy. What do we have, 24 acres of pristine campus, and then you've got these, the pods hanging out there. So it's at a premium. Storage is really at a premium, and this would be downstairs, away from just the public view, so to speak. And it would allow them to store equipment that now they typically have no room for. They've got to cram into one of those pods.
What kind of equipment? Sorry.
No, that's all right, go ahead.
What kind of equipment is it?
So nothing that would have gasoline or anything flammable in it. It's just like typically equipment to do maintenance, whether it's painting or spackling or.
So no medical equipment?
No,
nothing?
definitely not.
Okay.
No.
Harry?
So you'd be able to get rid of some of these pods?
Yes, I believe we would probably be able to get rid of at least one of the large ones or two of the smaller ones.
And how many do you have?
About 4 now.
Okay.
Not off the top, but it would definitely, by that, will help us the monthly cost for renting those pots.
Right.
Yep, I will give you the figure when I go back, but definitely will help on the P&L operation
Okay.
expense.
Yeah, it'd be nice to know. Thank you.
I want to ask about the snow plowing, because we've had noticed from other departments that there's going to be a problem with their snow plowing budget, and I'm wondering, Kelly, if you could take a look at that and let us know if there's potentially any issues. I know you're you're a facility 24/7, you need emergency access. How are we doing?
So we got an invoice for last month, close to $41,000. So we're expecting another one coming because of yesterday's storm. However, based on the budget and the actual expenditure, we had very little snow last year, and the snow plow services was $121,000. So compared that what we had, 40,000, let's say that another 80,000 is actually below budget. So the snowplow expenditure is actually within the budget.
Okay, well, as you get more bills, if there's an issue, just let us know, as sooner the better, I guess.
Sure. Thank you, Laura.
Okay. So I think that's all the questions we have. Joan and Agnes, I would just ask that we, to the issue of how we're funding prior year losses and the $2 million allocated in this budget based on the trends. I was trying to tie the numbers into past years, and I was having a hard time. So I've just asked that you take a look at that, and maybe we think about how we're doing this. I know last year the figure was 5 million, so. All right, any further questions? All right, so I'm going to do a programming note. So we're going to wrap up now at 3:30. We have a meeting planned on Thursday. Parks and Rec, who was supposed to be with us this morning at 9, is coming Thursday at 9 instead. Elliot has a report from both IAC and HR Committee is meeting tomorrow to discuss a couple of items pertinent to the budget. So he'll either give that report orally if he's here, or in writing if he's not able to be here. But my thinking is if we can be organized and get our thoughts and questions and follow-up meetings, we do not need to utilize the snow day that's in the schedule for Friday. So, all right, so I'm indicating we are not needing Friday, but that means that we need to be very organized for our decision day next Tuesday. So,
I would just suggest everybody keep an eye on the weather, because next Tuesday may be another snow day.
in which case it'll be Wednesday that we meet, but, all right, can I have a motion to adjourn?
So moved.
So moved, excellent, all right, 3:32, we are adjourned. Thank you very much.
Thank you all.